And hello from NephCure. I am Kristen Hood, the Director of Clinical Outreach, and I am proud to welcome you and happy to welcome you today to our NephCure U webinar on FSGS and the APOL1 genetic variant. I would like to introduce today our guest speaker, Dr. Jeffrey Kopp from the National Institute of Diabetes and Digestive and Kidney Disease, otherwise known as NIDDK. He is the current section chief in the kidney disease section. He's also a current consulting nephrologist for the NIH, an adjunct professor of medicine for the Uniformed Services, University of the Health Sciences. He's, like I said, he is the branch chief of the Kidney Diseases branch and a senior investigator for the NIDDK and NIH. And it would be our loss to not also mention that he is a retired commissioned captain with the U.S. Public Health Service. Currently, Dr. Kopp leads translational research group with the kidney disease section, studying focal segmental glomerular sclerosis and related podocyte diseases, with one of his current projects to determine the mechanisms by which this APOL1 variant damages the glomerulus of the kidney. So he is definitely an expert in the field, and we welcome him today for our presentation. And Dr. Kopp, I'm going to turn this over to you now.
Great. Thank you so very much for that nice invitation, that nice introduction, and for the invitation from NephCure to talk about this topic. So I will be giving you an update on FSGS and touching upon an important cause of that, as you heard, APOL1. See, do I advance the slides? It's not advancing for me. Can you advance for me? There we go.
Yeah, you got it.
Maybe it was a delayed action. I'm going to close this window here. So just to remind you, the histology of the kidney on the top left, you see a cross-section of cortex, the outer portion of the kidney, and you can see the glomeruli as blood-filled spheres connected to long tubules that you can see there as well. And you get a sense of their size. They're about 100 microns across, a microscopic structure. And the normal glomerulus, shown in a conventional kidney biopsy image, is shown below that tissue image. You see the sphere of the glomerulus in cross-section. The pink material is mesangial matrix. And then the open loops are the capillaries, where about, in all, 20% of blood flow goes through the kidney, an enormous amount for the small size of the kidney organ, to allow filtration to occur, to allow wastes to be removed, excess sodium, potassium, and so forth. And then the blue nuclei represent the command center of the cells. So that's a normal glomerulus on the bottom left. I don't know. Is my arrow showing up okay here?
Yes.
Good, okay. So now if we move to the top center image, we see a typical pattern of focal segmental glomerulosclerosis. So there's a glomerular scar, in this case near the vascular pole where the blood vessels are. So there's an increase in red staining collagen and other matrix proteins that will interfere with filtration, but the remaining part of the glomerulus is normal. So this is a segmental process. And it's also a focal process, is that initially only a very few glomeruli are affected, but over time, there's a progression in two ways. More glomeruli are affected over time, so it's less focal and more diffuse. And in addition, each glomerulus that's affected eventually scars down completely, and you can see no blood is flowing through this particular glomerulus because of the collagen deposition, and so no filtration is occurring. So it's a focal and segmental process of scarring, and shown here is just another image of a segmental scar. As I've got the label here to remind myself again that this progresses to a global process. Next slide. By the way, I'm happy to take questions. I think you have the option to put them into your webinar box. I'm not moving forward. If somebody can advance that.
Since you are sharing the
I have
screen,
to do that.
yeah, if
I'm
you
doing
want to
it right
click
now.
on the web browser and then
Oh,
maybe try,
got it. Okay, got it. Okay.
and then
Um,
maybe try advancing.
let's see if it works now. Oh, okay. Um, okay, so this now is in contrast another disease that's not FSGS, although I bring it up because sometimes people with FSGS present as if they have this disease, minimal change disease, particularly common in children and young adults, although it can be seen across the age spectrum. Here, the glomeruli look completely normal on light microscopy. However, we know by electron microscopy that there's podocyte damage because instead of the podocyte foot processes being distinct, we see what's called effacement or loss of those podocytes foot processes replaced by just a smear of podocyte cytoplasm. And this is a disease that responds well to steroids, for example, prednisone. Again, I bring it up here because sometimes the initial biopsy, if it only shows 5 or 10 glomeruli, may miss a focal lesion like FSGS, and only over time, if a second biopsy is done, may the FSGS appear. It probably was there all along, it just wasn't sampled by the first biopsy. So this is an important slide. FSGS is not a disease, although we often call it that in casual speaking. It's actually a set of syndromes, each of which comprises multiple different diseases. And I classify it, people have different ways to classify it. I classify it as 6 distinct syndromes, shown here as these 6 different clouds. The most common in our country are shown in the biggest clouds. So primary FSGS would be particularly of interest to many in the NephCure audience. This is a kind that often begins in childhood or in young adults, but it can happen at any age. It's believed to be due to a circulating protein, maybe a cytokine, maybe an immune protein. What's our best evidence for this? This is the kind that tends to recur after kidney transplant. And there are various candidates, but they remain just candidate proteins as a cause of primary FSGS. The next big of the 3 causes is adaptive FSGS, more common in adults, but it can be seen in children. And this is a mismatch between how many glomeruli there are in the kidney and how hard the kidney is asked to work. So a typical example would be an individual presents, maybe at age 15, maybe at age 50, with a history of premature birth. Nephrons stop forming when a child is born. So somebody born early doesn't have enough nephrons in each kidney. And if that individual overstresses the kidney, for example, becoming obese, there's an overworked form of FSGS that's quite distinct from primary FSGS with different therapies, and we'll come to that. So this is one of the key distinctions that it's important to make. The third major form, also an important distinction, is that we've learned based on work beginning 10 years ago now, 2010, from Martin Pollack in particular and other labs, that there are variants in this gene APOL1 that I'll be talking more about that explains why 72% of African Americans with FSGS have this. It's due to 2 copies of a variant of the APOL1 gene, and it can act as a mimic. It can appear as primary FSGS, or it can appear as adaptive FSGS in particular. So those are the big 3. It's
Dr.
also important. Sorry, go ahead.
Yeah, we have a question from Talia. She's asking, does FSGS seem to be predominant in Black African Americans versus Black people in other countries?
That's a wonderful question. And it appears that individuals of sub-Saharan African descent are prone to get this FSGS wherever they live. The highest prevalence of these gene variants I'll be talking about are in West Africa. So people of West African descent, which of course represents the population that were brought to this country as slaves, is enriched in APOL1 variants. Much less common in East Africa and an intermediate degree of frequency in sub-Saharan Africa. So 72% of African Americans with FSGS have 2 copies. And as we move forward towards therapies, one of my final slides will talk about targeted therapies for FSGS. There is now interest in targeting the protein that is made by the APOL1 gene as a way to get directly to the heart of the problem. So those 3 big clouds are the most common ones. The yellow cloud at the top left, there are variants in over 50 genes. I'll be touching on that. Individually, they're relatively uncommon, but they're very important to know about because some have specific therapies that are quite effective. And in general, with a few exceptions, they don't respond to steroids. So this is something to keep in mind for the nephrologist and families. And then for completeness, certain viruses can drive this, HIV in particular. Fortunately, with HIV under control, we see much less of this. Also cytomegalovirus, possibly parvovirus, possibly Epstein-Barr virus. And certain medications can cause this. I'll just touch upon one, interferon, which is a host response gene. And when it's turned on by a viral infection, it drives APOL1. So in fact, this is in some ways a subcategory of APOL1. So again, the big picture on this important slide, 3 main causes, primary adaptive and APOL1 FSGS. And then particularly for this group, thinking about very high penetrance genes that cause FSGS. So maybe I slipped over the idea that APOL1, although it's a genetic disease, it seems like it takes something in the environment to trigger it. So not everybody who carries APOL1 variants, 2 copies, will get kidney disease. Our best evidence is that only, or estimates, is that only about 20% will. So that's why I pull it out as very different from the so-called Mendelian gene variants that either are autosomal recessive or autosomal dominant or mitochondrial, where the inheritance is much more clear. I know that was a complicated slide. There's a lot on there, and I'm happy to take questions now or later. It gets simpler from here, I hope. Okay, next slide. Okay, so let's jump right now to this issue of African Americans. The lifetime risk for getting end-stage kidney disease, this is not just FSGS, is about 8% in Blacks and about 2% in whites. This risk extends across diseases. It's FSGS, but it's also diabetes. It's also so-called hypertensive kidney disease. And if we look on the right at the African American to European American incidence ratio, for all causes of end-stage kidney disease, it's about 3. Same for diabetes. For hypertension attributed kidney disease, many would call this just hypertensive kidney disease, it's 5. And we now realize that's another APOL1 disease. In other words, it's not that uncontrolled hypertension damaged the kidney, it's that these individuals have APOL1 variants that then damage the kidney, and hypertension arose as a part of that. So as we move towards gene therapy, or maybe better to say genetically informed therapy for FSGS, it's so important to include this group of people, many of whom have not had biopsies, but may respond very well to these new therapies. And then within glomerular disease, African Americans are much more prone to get FSGS and so-called AIDS nephropathy or HIV nephropathy, which is nothing more than a subset of FSGS. Next slide. There, thank you. So what is APOL1? It's a minor protein component of the so-called good cholesterol, HDL cholesterol. It's not even seen, I think, on this, this figure. Its main function appears to kill trypanosomes, the cause of African sleeping sickness. So in the bottom right, you see red blood cells from a blood smear that was taken from an individual who was infected with sleeping sickness, and you see a trypanosome, that sort of comma-shaped single-cell organism causing the disease. And it turns out that APOL1 probably has as a major function to kill these parasites. As an aside, there's at least one individual who has no copies of APOL1, and they get along just fine. So it doesn't seem to be required for normal physiology. And instead, it seems to evolve as an anti-trypanosomal protein. Well, it turns out in the race to between parasite and host, the trypanosome evolved a countermeasure protein that binds APOL1 called SRA, serum resistance antigen. And these variants arose in sub-Saharan Africa probably relatively recently, on the order of about 50,000 years ago, as a way to undo or restore killing of the trypanosome. So who's at risk for APOL1 FSGS? It's people with recent sub-Saharan African ancestry. Again, I make that point that everybody on the planet has sub-Saharan African ancestry if you go back far enough. Next
Dr.
slide.
Kopp,
Yes.
we have a question on Facebook from Marie. She's asking, is this genetic? We have a family member that wants to donate, but no one will tell us if it's genetic, so no one wants to donate.
So I think that's an excellent situation where genetic testing is important, because particularly with regards to APOL1, because genes run in families. So if somebody has APOL1 FSGS, then it's possible that family members would have 2 copies and be at increased risk. And in general, we recommend against people with 2 APOL1 risk alleles donating a kidney. There's not a lot of data, but there's a little bit of data suggesting a concern, and we would argue, we would generally counsel that person not to be a kidney donor.
And then we have one, yes, that's great. We have one more from Talia. She's saying, just to clarify, more people of African descent carry this APOL1 gene, but that doesn't mean that everyone that has this gene will have FSGS.
Perfect. So everybody has the gene. These genetic variants are limited to people of sub-Saharan African ancestry. And my best estimate, and I put it in papers, but I can't guarantee that I'm right, is that 20% of people who carry 2 APOL1 risk copies will get FSGS in their lifetime. But I'm the first one to acknowledge that that's based on back of the envelope calculations. But I think the risk is well under 50%. So what do we tell people? I would say if it's a family with FSGS, African-American family, that we should certainly test people with FSGS. It would be reasonable to test unaffected family members or people in general. If so, then those individuals who have 2 risk copies and have normal kidney function, no protein in the urine, should probably have their urine tested every year or every couple of years. But I'm a little bit hesitant to saying this is absolutely the right way to go, because I don't have any data that tells me that early detection of this disease makes a difference. It should. We believe that early detection of many diseases makes a difference, but until we have a formal study that shows that we can effectively treat early disease, halt it, or greatly slow it down, I can't with confidence say genetic testing for every African-American or every African-American who has a family history of kidney disease is going to be helpful. I know that's not a very satisfactory answer, and hopefully in the years ahead, we'll have a more precise recommendation.
Dr.
By the
Kopp?
way, you guys are a great audience. These questions are coming and it's wonderful.
Yeah, one more, and then we'll go on to the next slide. This is from another attendee of the webinar, would the fact of having 2 APOL1 genes put those patients at a disadvantage for finding a transplant match?
Only to the extent that if an individual has 2 risk copies, it's possible their family members might be at greater risk to have 2 risk copies, and therefore they should not donate, I believe. Now that's not an absolute. If a parent of a child with APOL1 is a suitable donor but has 2 risk copies and really wants to donate, I think that's a question for them to decide with their nephrologist. I don't think they necessarily would be denied the opportunity to donate. But ideally, knowing that the parents, say with 2 risk copies, ideally that individual would not be the donor, and we would find somebody else who would be at less risk of, as a donor, having a poor outcome. Generally, living donation is very, very safe. In part, that's because we screen people very carefully. You can't have cardiac disease, you can't have pulmonary disease. But this is a gray area where I think it's a lot is left up to the patient and the nephrologist to decide what is appropriate. Okay, continuing on APOL1, it can manifest as different forms of the overall 6 forms that I talked about of FSGS. It can look like primary FSGS. It could be a 15-year-old presenting with heavy proteinuria. They respond to steroids and go into remission, and it can recur after kidney transplant, although we don't really understand that. Well, I should back off. I think we have an idea why that happens. It had nothing to do with the genetics of the kidney. It's that that person probably had a circulating factor that I referred to earlier that likely plays a role in primary FSGS. But APOL1 FSGS can also look like adaptive FSGS. Sickle cell disease is a disease of hyperfiltration through the glomeruli, and so individuals with sickle cell FSGS are likely to have, may have 2 risk alleles. And interestingly, CKD associated with prematurity. So again, nephron development stops at the time of birth. So that's a risk for kidney disease. And if you pile onto that APOL1 risk alleles, that double hit makes it more likely that that premature child, baby, as they grow to childhood and adulthood, may be more likely to get FSGS, particularly with APOL1 as a second hit. Again, not true for everybody in that situation, but it's a risk. Viral FSGS, we've known for years that HIV-associated nephropathy, more common in Blacks. These are very, very high odds ratios that I'm showing you. We now understand that that's almost exclusively seen in people with 2 or sometimes 1 risk copy of APOL1. We know that the virus turns on this protein interferon that then turns on APOL1. And lastly, if you're given interferon for another purpose to treat another condition, and you have 2 APOL1 risk alleles, that can cause FSGS. Not a common situation, I'll acknowledge. Next slide. Moving on to the next slide.
Yeah, if you just use your cursor.
Okay, okay.
Yep, and I think you can click.
Yep, okay, here. Got it, thank you. So how is FSGS treated? There are 2 main disease categories I want to cover here. Somebody with primary FSGS or APOL1 with primary features, namely heavy proteinuria, low serum albumin. First of all, everybody on this table gets the same basic treatment. Low sodium diet, diuretics, maybe just a low dose of a thiazide diuretic, and RAS blockers, by which I mean angiotensin receptor blockers or ARBs, or ACE inhibitors, and that together with the diuretic as a 1-2 hit, and actually as the low sodium diet as a 1-2-3 hit, are really potent ways to reduce proteinuria in all glomerular diseases. And they're pretty safe, and they have relatively few adverse events. So this really should be the bare minimum. The main side effect is lowering the blood pressure too far, and so that just has to be watched out for. Now with adaptive FSGS, same thing, but now if somebody's obese, as happens with some forms of adaptive FSGS, then weight loss will help. So beyond that, first-line therapy for primary FSGS, whether it's APOL1 or not, is steroids, by which I mean prednisone, typo here, I meant to type in prednisone or prednisolone or methylprednisolone, usually given orally. There are pulse therapies. We've also tried another one, dexamethasone. I think it doesn't matter too much which one you're given. And first-line therapy for the adaptive patient is just the diuretic. Generally, steroids are not thought to be beneficial in somebody who has features of adaptive FSGS. If steroids are contraindicated or fail to reduce the proteinuria, then on to various other therapies, mycophenolate, and rituximab are currently therapies, and their experimental therapies I'll come to at the end. Next slide.
You may be able to just
I'm
click.
sorry.
No, it's okay.
Right.
Perfect.
I'll learn. So clinical trial phases. So as you are looking at different trials or going into clinicaltrials.gov, which I'll bring up at the end, you'll see these phases. And I think many of you know, but I just want it to be complete. So the primary goal of a phase 1 study is to ask, is the drug safe at different doses in the population that might receive it? So often in the setting of nephrology, we're adapting drugs from other diseases, And we still need to first test that drug out in our patients with low serum albumin, on multiple drugs, with edema. How is that drug safe in our population? Phase 2, at one or more dose levels, does the drug work? And work really means reduce proteinuria, because generally these are short-term studies of 4 weeks or 8 weeks, and we're unlikely to see more than a proteinuria reduction. We're not going to see stabilization of GFR decline. Then the phase 3 study is the key so-called registration study. Really, it's FDA approval that is the endpoint here. Is the drug better or safer than a current therapy? And perhaps I should have said, or equivalent to a current therapy, because there might be reasons to use a drug that's no better than what we have now in one parameter, but might be more desirable for another reason. And then phase 4 is very important. After a drug is approved by the FDA and is being widely used, it's really important for the company, generally it's companies bringing this to market, to continue safety evaluation. And that's why it's so important for nephrologists and patients, if adverse events arise, to make sure that's passed to the nephrologist, passed up to the FDA, so they get a better handle as thousands of patients are being exposed to the drug. Are there safety issues that weren't apparent in the initial trials that in a rare disease like FSGS may only involve 30, 40, 50, 60 patients, and there may be rare but important adverse events to know about. Again, I usually say I talk fast. I'm from New York. I can't help it, but please stop me if you have questions. Okay, what are some of the current trials for native kidney as opposed to recurrent FSGS after transplant? And this, I think, would be of particular interest to this audience to see how many drugs, let's see, 3, 4, 5, 6 drugs are currently in various trials at phases 1 through 2 or 3. So this was not true 5 years ago, 10 years ago. And it's in part credit to many people on this call, to organizations like NephCure, to other professional organizations like American Society of Nephrology, National Kidney Foundation, that have really pushed to get drug companies interested in these trials, have put together platforms that make it easier to recruit. There are consortia like Neptune and CureGN. And so I think we're making progress that we weren't making before. Again, I won't go into details. I don't know that much about some of these drugs in particular, but I think the idea there are many options being tested. I know a lot about Manac because it's a drug that I'm working on, a precursor of sialic acid, a sugar that's necessary for the normal function of several podocyte proteins. We don't know which of these is going to make it, but with this number in progress and more coming, we will have better drugs, I'm convinced, in 3 years, in 6 years, in 9 years than we have now. And I realize that's frustrating for somebody who has a child or an adult that's not responding to current therapies, but there will be better therapies, I believe, in the near future. Oops, I think I went too far. Did I double click? Can I go back one slide?
You can if you click your back arrow button.
Oh, there we go. Okay, yeah, this is an important slide, right? Yeah, I did that one. I'm glad I didn't skip over this one. So I think a lot of you are wondering, should we be asking about genetic testing? So why test? It may identify genetic cause and give an explanation why this disease happened. Even if there's not a therapy, sometimes it can be helpful to have that answer as to why it happened. So bullet number 2, it may provide an explanation. Most genetic forms of FSGS don't respond to steroids. There are now over 50 genes, as I mentioned, where variants drive FSGS, and there are 1 or 2 that are steroid responsive, but most should be treated at the outset as adaptive FSGS. In other words, low salt diet, ACE or ARB, diuretic, weight loss if obese, and avoid the toxicities of steroids. Now, some of those individuals may respond to cyclosporin, which although or mycophenolate, which although they're immunosuppressants, do have direct effect on podocytes. So I'm not ruling out a genetic patient getting other agents, but I don't think, with rare exceptions, that the genetic forms of FSGS are steroid responsive. Another reason to test, knowing about a gene that caused disease suggests that it runs in the family. This may have implications for other family members, that it might explain or predict kidney disease. It might suggest that, particularly in the age range where that particular form of FSGS presents, that individuals might want to have urine protein tested to try to detect early disease. Because in all diseases, early disease is easier to treat than late disease. Now, the issue of genetic discrimination comes up. And so a number of years ago, Congress passed a law, the Genetic Information Non-Discrimination Act, that prevents certain kinds of discrimination, particularly health insurance, from being affected by genetic information, health insurance, and I believe life insurance as well. But that doesn't mean that there aren't other forms that might potentially play a role. So I think it's something that does merit discussion. But in general, I think knowing about a genetic cause outweighs the downsides.
Dr.
All
Kopp,
right.
we have a couple of,
Yes.
couple of questions, if that's okay.
Please, yes.
The first one is from Kevin. He's wondering, is genetic testing routinely done when being considered as a living donor?
You know, it's a great question. And I don't really know the answer to that because I'm not heavily engaged with the transplant community. I would imagine that the nephrologist is taking a history and hears that an individual in the family, we're assuming that this is a family donation, that say a child has kidney disease and maybe an uncle wants to donate. I think that's an excellent conversation if it's not being raised, to raise with that nephrologist who's evaluating the donor. As I think people know, it's important ethically, and this is always done, for the donor evaluation to be done by a nephrologist who has no tie to the patient who is potentially getting the kidney. So there's no conflict of interest, if you will. But that nephrologist should be thinking about and know about the nature of the disease. When did it present? How did it present? Did it look very strongly like primary FSGS, making genetic causes much less likely? So I think this is an important question. I don't think everybody who's going to be a kidney donor needs to have genetic testing, but I don't think it hurts. But I could see a situation where the history is so compelling that this is not genetic FSGS, that it's not necessary. I think that was one question. Was there a second one?
Yes, sir. How hard is it to get an APOL1 test? Will my nephrologist be able to get me one at her office?
Absolutely. So the blood goes off to one of two sites that are doing it. I happen to know one is at Wake Forest. I'm forgetting where the other one is, but there is a website that I don't have at the top of my fingertips that shows where all genetic testing can be done. I can provide that to you afterwards. But yes, this is readily available. Blood is drawn, has to be carefully labeled, obviously, and is sent off to these sites. So this is definitely available, and your nephrologist will know about it or can ask somebody who does know how to do it. These are what are called CLIA certified, meaning the laboratory is certified. Great pains is taken not to mix up samples. This is so important, as it is in all blood testing. And so that's why I'm a researcher. I don't claim that my tests are done at that level of rigor. In particular, the transportation issues, the careful labeling. We try not to make mistakes, but you want a clinical grade genetic test, not a research test.
Okay, I have another question for you. We have a comment that says, wow, this is very insightful. Would it be helpful for a patient with genetic FSGS who wishes to procreate, have their partner get tested to see if they have the APOL1 gene variant in hopes that it will decrease chances of a child getting FSGS? Right.
So I think it would. Keep in mind that my estimate, and this is a back of the envelope calculation, I'm the first to acknowledge it, is that only 20% of 2 APOL1 risk allele individuals will get FSGS in their lifetime, or another kidney disease like hypertension, misattributed, if you will, kidney disease. But somebody might say, well, 20% is still very high. And so two people who think that they might have APOL1 might in fact go ahead and take the course of action that you're proposing. This is an area that would be reasonable for people to make the decision both ways.
Okay, another question. Does the presence of two APOL1 alleles constitute a pre-existing condition? The direction of the question is, does it impact an individual or a family's ability to get insurance coverage?
Right. So there is this law that was passed, GINA, Genetic Information Non-Discrimination Act, passed under President Obama, that prevents a health insurance company from altering rates based on genetic information. To my knowledge, that does not extend to life insurance. But with regard to health insurance, absolutely, that will not impair your ability, raise your rates. I think the insurance companies are well aware of this law, and I'm sure are adhering to it.
Great, thank you. You can move on to the next slide for now.
So what are the downsides? Anxiety about extrarenal features that have not appeared yet and may never appear. I'm not talking so much about APOL1, but other forms of genetic disease. Guilt about having the guilt on the part of the parents about having passed on the causative disease, causative gene, excuse me. And if other family members are undergoing testing, sorry for the typo there, genetic testing could disclose unexpected family relationships. It requires 2 copies to get nephrin associated FSGS. One parent has a mutation, the other doesn't have it. Where do you go with that information? Now, maybe the clinician can hem and haw and say maybe it was a defect that arose in the process of embryonic life, early life. And that may be true, but it does raise questions about so-called misattributed paternity. So it's something to keep in mind, but usually a physician is aware of the sensitivity and will do their best to deal with it. But I think it's good for people to at least keep that in mind. All right, reason to do genetics. So I just told you reasons not to do it, reasons to do it. It may provide an understanding of why someone has disease. You could say, well, what does it matter? My child has nephrin FSGS, or I'm an adult. But I think, and for some people, it doesn't matter. For other people, they want to know why I got this or why my child had this. And knowing a proximate cause, it was the genetic variant that drove damage to the podocyte, the key cell in the glomerulus that is injured in FSGS, provides some manner of, how to put it, of coming to an equilibrium on it. And if that's the kind of person somebody is, then I think that can be helpful. It's important that most forms of genetic FSGS, I said there are over 50, talking about non-high penetrance F forms, that there are very few that respond to FSGS, to steroids, but there are some. So knowing what it is might spare somebody a course of steroids, and would facilitate future prenatal testing because you would know exactly what gene you're after. All right, next slide. Very important topic, FSGS recurrence after transplant. I think we've touched on this before. Somebody's had FSGS for 2 years or 10 years or 15 years, goes to end-stage kidney disease, gets kidney transplant, and within days to weeks, maybe months, proteinuria is back and a biopsy shows FSGS. It's most common with primary FSGS, which makes sense. We think this is due to a circulating factor, and so it makes sense that it comes back after kidney transplant. Admittedly, there's a bit of circular logic there because we think primary FSGS is a circulating factor because it comes back after transplant. And there are 2 candidates, as I mentioned, SUPAR and cardiotrophin-like cytokine 1. Both will need extensive further validation, but I think both may eventually pan out, which means we may eventually have specific therapies. In fact, I think Jochen Reiser in Chicago is working on therapies against SUPAR. Typically, the recurrence occurs hours to a few days after transplant. So in this setting, usually protein is checked in the urine daily after transplant. Less common with APOL1 FSGS than with primary, but it can happen. It's very uncommon with adaptive FSGS. Again, the individual who might be overweight or hypermuscular and has a form of FSGS with modest proteinuria, preservation of serum albumin. Very rare with genetic FSGS. There are one or two exceptions. How do we treat FSGS when it's come back after transplant? Generally, we assume that there may have been a plasma factor, because that seems like the most likely way to explain why it came back. And so people have a plasma exchange where there are 5 treatments where a certain amount of their plasma is removed, restored with normal donor plasma, or possibly normal donor plasma. And often individuals will go into remission, strengthening the evidence that there was a circulating factor that you've taken has come off. However, often the remission is transient. So it's not necessarily a long-term solution, but there are occasional patients, we don't understand it, where a course of 4 or 5 plasma exchanges will put people in a sustained remission. Again, another thing we need to know more about. It may lead to loss of kidney transplant function and a loss of the allograft, so that after 6 months or a year or 2 years of heavy proteinuria, it may lead the transplant to not function. And once somebody's had recurrent FSGS in the first transplant, it's quite likely to affect later transplants. That doesn't rule out that a transplant might not be offered, but it's something that patient, family, nephrologist needs to keep in mind. Next slide. Oh, I'm sorry. FSGS for patients, all online. If you Google NIDDK, which is my institute, Institute for Diabetes, Digestive and Kidney Disease, NephCure Kidney International, sponsoring this activity, and then PubMed, which I think people know is a free website. Sometime in the Obama administration, it was kind of upgraded, made free to everybody. And many papers there are available for download. Not every paper. There are some journals that do charge a fee. The abstract is always available, 150 to 250 word summary, and many papers are available. And if sometimes you can write to the author and say, I can't get the full article, could you send it to me? I know I get those requests, and I'm happy to do that. So people who want to learn more, there's lots to learn about FSGS. All right, I guess that's my last slide. I tried to not fill up the whole hour, and I'd be very happy to take your questions. You've been asking great questions, and perhaps you have some still to ask.
Yes, sir, I do. The first one that I have is, what is the risk of being misdiagnosed due to the uncertainty surrounding the risk variance?
So I'm trying to think what this might mean. So being misdiagnosed with FSGS, but not knowing it's due to APOL1, is that? What do you think?
Yes, I'll read it again, I'm not sure. He's just asking, is there a risk basically of being misdiagnosed due to the uncertainty surrounding the risk variance?
So I would say at this point, knowing that you have 2 APOL1 risk alleles is not critical because we don't have targeted therapy. I thought I actually had another slide. I guess I don't, may have taken it out. There is a company that, at least 2 companies that are working on direct therapy against the APOL1 variant. One uses what's called antisense RNA that binds to the sense RNA in the patient, and that double-stranded RNA is degraded so the protein is never made. So if that line of attack is successful, and there are other approaches being tested as well, then let me just see if I go forward one. Can I go forward one, or did I may have made that. So knowing that you have APOL1 FSGS will become important. Why else to know it? I think I touched on this. It tends to be rapidly progressive, but sometimes does respond to therapy. So knowing your APOL1 status would encourage patient and physician to try something. If it doesn't work, try something else. So those are the arguments to know about APOL1. For all the other genes, it provides an explanation for why somebody has disease. For mitochondrial diseases, there's a therapy that's readily available, COQ10, available in your Costco, that helps restore mitochondrial function. And there are 2 or 3 others that have specific therapies. So I hope I answered that question. If not, my email is readily available. Google me. I'm happy to either talk by phone or by email if people have questions that don't get answered.
Great. Another question, is APOL1 FSGS a worse form of FSGS than the others?
It is more likely to progress to end-stage kidney disease more quickly than many of the other forms. Not, I won't say every form, but yes. So I would say it is a problem for us nephrologists and our patients with APOL1 FSGS. I will agree with that.
Before I ask my own question, I would like to acknowledge that we have 3 sponsors today for our presentation. Retrophin, the Pfizer Foundation, as well as Chemocentric. So I would encourage those of you on our live streaming with Facebook or within our webinar, if you have questions, please type them in now. We would love to answer them as we are here. In the meantime, Dr. Kopp, I have a question for you. Do you feel that there has been a misattribution of APOL1 kidney disease to hypertension, perhaps due to a physician misunderstanding of the disease mechanism? And if so, how can patients approach their physician about this?
Right. So I think what you're describing would be an African-American patient who's had hypertension for a few years or many years, now has some protein in the urine. And historically, many of these patients were told your blood pressure has affected your kidney. That still is true for many individuals of all races. However, for African Americans in that situation, they need to educate their physician, be it a primary care physician or a nephrologist. Doctor, do you think this could be due to APOL1 genes that might be causing kidney disease that lead to the hypertension instead of the reverse? And if so, could I get tested? So I think that's the approach.
Great. Another question. You are obviously an expert researcher and know all about APOL1. Will my nephrologist, who's not a researcher, know this? And how do I talk to him about this?
Yes, I believe that nephrologists across the country know about APOL1. It's been a big story in the nephrology field because it's been a puzzle for years. Why do people of African descent get more kidney disease? I think all nephrologists will know about it. They may be less able to say, what's the next step? And so hopefully that nephrologist has a couple of options. One is to read up and see what the next step is. Another is to find a university where people may be more oriented to this, may attend seminars, may talk to each other more regularly. So I think I would leave it up to the primary nephrologist how best to approach it, but I wouldn't be shy about saying to that nephrologist, I really want to pursue this possibility. I understand genetic testing is commercially available. Can you send a sample? And if it comes back positive, have a conversation with that nephrologist. Who do you think is best able to guide me as to the best approach, my prognosis, testing other family members? I think many frontline nephrologists will be happy to pass that on to a center that has more expertise in genetic kidney disease. Most nephrologists, I believe, have more more patients, or at least as many patients as they can cope with. We have an epidemic of kidney disease in our country, as I think everybody knows. So I believe that request for a referral to a specialized center would be met graciously.
Do you suggest genetic testing as a diagnostic tool in all African Americans with proteinuria or with a known glomerular disease?
I'm inclined to do so. There might be exceptions. Somebody who has another disease that clearly causes kidney disease. But even then, so for example, diabetes, we know that diabetes causes kidney disease. We know that people with APOL1 risk alleles can masquerade as diabetic kidney disease, but it's true that most diabetic African Americans with protein in the urine will not have two APOL1 risk alleles. It's just that's a population that's enriched compared to the general population. I think I mentioned 13% of African Americans have two APOL1 risk alleles. I can't quote numbers off the top of my head, but I think for diabetes, it's something like 20%. It's nothing like the 72% of African Americans with FSGS. So it doesn't explain all of diabetic kidney disease, but it is one possible explanation for a diabetic with proteinuria who's African American. So I would argue for testing because increasingly we'll have targeted therapies available.
That's great. One more question I have so far. This also from Kevin. This presentation is and the information has been excellent. How do you suggest we improve dissemination of this information to the African American community?
You know, we had a conference that touched heavily on this. NIDDK recognized that it was time to think about how to get this out. NIDDK being the institute I work with in NIH, we got together community members, experts in genetics, experts in medical communication, and nephrologists. And if, Kevin, if you will contact me, I'll send you the report from that conference. But it's going to take much more than NIDDK getting this word out. It really will take concerned individuals like yourself to think about in your community how to disseminate it. I would love to see newspaper articles written about it, talks given in churches. You know, there are many ways to get this information out. NIDDK wanted, like you, to begin this process, but it's going to need many, many partners. So thank you for asking that question.
Dr. Kopp, do you believe there's a benefit to getting genetic testing for APOL1 after you've had a transplant?
So after you've received a kidney, would it be worthwhile to test whether you yourself have 2 risk alleles? And the answer is no. It appears to be that the outcomes of recipients with 2 APOL1 risk alleles are identical to recipients who have 0 or 1 risk alleles, which tells us, although APOL1 circulates, remember it's on HDL cholesterol, it doesn't seem to be the HDL cholesterol bearing APOL1 that damages the kidney. It is the kidney expressed APOL1. And the reason we know that is from the kinds of patients you're exactly describing, that individuals with 2 APOL1 risk alleles in their genome who get a kidney transplant that doesn't have APOL1 are at no increased risk for getting kidney disease.
Great, thank you for
So
clarifying
again, the
that.
disease, to put it in a nutshell, APOL1 disease travels with the kidney. Now, APOL1 kidney disease travels with the kidney, not with the plasma, not with the HDL cholesterol. Now, something I haven't touched upon, there is some data that's still not totally firm about does APOL1 contribute to cardiovascular disease. That's a complicated topic that I didn't touch on, and I think it still is an area of controversy.
Great. A couple more questions. One is a comment from Louise. She says another great way of obtaining the APOL1 testing is to find a local genetic counselor, and she mentions the National Society of Genetic Counselors. Do you, Dr. Kopp, believe that obtaining information from a genetic counselor is also very helpful for the patients who get genetic testing?
Absolutely, and I was remiss in not mentioning that pathway. So absolutely, you don't need to go to a physician. You can see a counselor. I believe they can do the testing, and then they would probably counsel you and then say, you know, I've been counseling you about APOL1, but you probably want to see a nephrologist who has expertise in this area. But that's an excellent pathway as well. Great.
From another attendee, you mentioned diabetic kidney disease a few minutes ago. Did you say that APOL1 may play a role here too?
It masquerades as diabetic kidney disease. So yes, so individuals who have diabetes and proteinuria usually do not get a kidney biopsy. If everyone did, then we would see some have diabetic nephropathy, shown as thickening of that glomerular basement membrane I showed. Some have another disease like FSGS, but we didn't know until we did a biopsy. Since we usually assume that people with diabetes have diabetic nephropathy when they get proteinuria, we don't do that biopsy. So who might you suspect? Well, diabetic kidney disease, eye disease, and to some extent nerve disease tend to travel together. They also tend to occur in a type 2 diabetic, well actually type 1 and type 2, after about 10 to 20 years of diabetes. That duration is less secure in type 2 diabetes because we don't always know exactly when that starts. So here's where I'm going. A diabetic who is unusual, they've had diabetes for 3 years and they suddenly have substantial proteinuria. Their eyes are normal. They have no neuropathy. That suggests they don't have diabetic kidney disease and should probably have a kidney biopsy to see what they do have. So yes, diabetics can get APOL1 related kidney disease. It would manifest differently from typical diabetic nephropathy, but it would be important to distinguish.
Great, thank you so much. I believe that is all the questions that we have currently. As I close this session, Dr. Kopp, thank you so much again. And thank you to our sponsors, Retrophin, the Pfizer Foundation, and ChemoCentrix. I would also like to mention that if you are interested in more information, you can definitely reach out to us at NephCure. You can send me an email at khood@nephcure.org, and I would be happy to send you the link to this recording of the presentation. Again, we also have a website, kidneyhealthgateway.com, and which is a patient-centric clinical trial tool where you can enter your information and see if you would, and you can inquire about different clinical trials that are out there for FSGS to include the APOL1 variant. So thank you so much for attending, everyone. It was a great presentation, Dr. Kopp. This is a wealth of knowledge, and I know that everyone has really enjoyed it.
Thank you so much for the opportunity, and thank you to all the participants.
Thank you so much. Have a great day, everyone.